The objectives of the talk today are that you will understand the etiology of type 1 diabetes, understand the main principles of management, understand how to choose an insulin dose, and understand the basic precepts in the care of DKA. So just as an introduction, I'm going to give you a little quiz to think about what causes type 1 diabetes. So question A is eating too much sugar. Question B is eating too much fat. C, or answer C, would be a problem with the immune system, and D is a problem with the beta cells. These are all real answers that we've heard. In a group setting, often physicians and nurses will choose maybe C or D, so you might think about those two, and the right answer is C. The primary problem is with the patient's immune system. And here's a nice picture of an islet to show that. So these are mouse islets, and to orient you, the islet over here is a grouping of beta cells. You know that they're beta cells because the insulin is being stained red. Just for reference, each cell is marked by a blue dot because that is a nuclei. So this is a very healthy, nice islet sitting within a pancreas. And over here is an islet from a mouse who is just starting to present with type diabetes. And you can see that the insulin staining is really becoming hazy. And you can see these infiltrates, which is called insulitis, which is showing all the lymphocytes, these little blue, primarily nuclear cells that have very little cytoplasm, infiltrating and attacking the beta cells in the pancreas. So just to back up, thinking about how many people have diabetes, of course, type 2 diabetes is what is in the media a lot because that is a worldwide recognized problem. Type 1 diabetes is on the radar screen of most pediatricians, but is a much smaller piece of diabetes. About 5% of all people with diabetes have type 1. In the U.S., that leaves about 3 million people with type 1 diabetes are our current estimates. And in terms of children, it's probably about 150,000 currently. And that's about an estimate of 18,500 new children and adolescents with diabetes per year. Worldwide, that's about 78,000 new diagnoses per year in children and adolescents. The prevalence is 1 to 300. And interestingly, it's been noted to be increasing in the U.S., in Europe, and also worldwide at a rate about 2 to 3% per year. The incidence varies greatly worldwide. So the U.S. is about in the middle, matches Canada and matches most of Europe with an incidence of about 10 to 20 per 100,000 per year. Some countries, China and Venezuela particularly, are lower. Finland and Sardinia have a known high incidence rate of this, most likely due to a genetic founder effect. Incidence varies by race ethnicity in the U.S., and there is some data recently published out of Search for Diabetes and Youth Study. So it's highest in non-Hispanic white, lowest in Native American youth, and the other falling in the middle. So these data sort of suggest some etiology, certainly that there's a genetic susceptibility, and certain genes have been found. Most of these genes are linked, as you may expect, to the immune system, and specifically in terms of antigen presentation. And those that you may have heard of, although there are others, are the HLA genes. There's also going to be a trigger, and that's suggested by the epidemiological data that this is really increasing now at a faster rate than you would think that the genetic background would change. So what are the triggers? This is not an exhaustive list, but it's some that are being actively studied. A virus, early exposure to cow's milk, lack of parasitic or other infections, which would be sort of the farm theory, vitamin D deficiency. There hasn't been a slam dunk link to any of these, but they're all currently under investigation. And I want to highlight them a bit because they're something that when your patients are diagnosed, they're going to have at the top of their mind. So let's take one in particular that's been in the news recently, in enterovirus. The link between enteroviruses and a risk for type 1 diabetes dates back about 40 years and has been actively studied on and off that whole time. Most of these studies are going to be small cohorts of patients in retrospective. Recently, this is the kind, there's been news, and it's the sort of type of news you see often in type 1, and you don't know, well, is it really that they found the final thing here, or is this a small piece in the puzzle? And patients really struggle with this, so your help with this is going to be really helpful for them. So the news in MedPage is study links enterovirus in kids to type 1 diabetes. Medical Daily, type 1 diabetes is 50% more likely in children who have been infected with enterovirus. So just to delve into this paper was published out of Taiwan in October of 2014 online in Diabeticology. And they asked this question of whether enterovirus is linked to type 1 diabetes risk. They had a really interesting setting to be able to do this because in Taiwan, 98% of the entire population is covered in one national health insurance system. So they could look at claims from basically their entire population. So they looked at the claims from 2000 to 2008 in children and adolescents up to age 18. They looked at claims for enterovirus and looked at which people who had enterovirus went on to develop type 1 diabetes and which of people who had not had a claim that were matched did not go on to develop type 1 diabetes. And here's what that looked like. So they found about 576,967 children who had a claim for enterovirus. And then they matched them with another 570,000 children who had not had enterovirus in those 8 years or the prior 5 to 8 years as well. And they found that the incidence was 6 per 100,000 person years in the group who had enterovirus in their history and was a little lower at 4 per 100,000 person years in the group that hadn't had enterovirus. This was found to be significant with a 95% confidence interval that was greater than 1, 1.19 to 1.83, which gave a ratio of about 1.5, or as the media claimed, about a 50% increased rate. Clinically, it would be something I would put more in a piece of the puzzle than sort of the answer. So if you think about that, if your chance of developing diabetes is less than 1, increasing it to less than 1.5% is significant potentially, but not the answer that if we treat or have a vaccine against enterovirus that we'll see diabetes go away. It's still happening on both populations. So with that as a background, I want to show you our current model of our thinking in type 1 diabetes. Basically, there is a beta cell mass, which is the entire beta cell mass that you're born with. You're born with a genetic predisposition, and then there is a putative environmental trigger, which remains basically unknown at this point, or it may be a combination of several types of triggers or one trigger several times. This institutes the autoimmune attack, beta cell injury, and insulitis, which is the picture I showed you with the infiltrating lymphocytes. We first can pick that up in peripheral blood samples in something called tetramers that show us the T cell response. That's followed by humoral autoantibodies, which are the first signs we can screen for clinically. Then you start seeing, as in type 2 diabetes, loss of insulin effects. And the first is the loss of the first phase insulin response, followed by glucose intolerance, and then clinical presentation. As you can see here, there is beta cell mass left at the time of onset. It's probably between about 30 and 50%, depending on the person, the age, and the length that they've had disease at that point. Interesting work has been done in the U.S. mainly in a study consortium called TrialNet to sort of use this model to think about predicting the risk of type 1 diabetes in family members of people who have type 1 diabetes. So the risk of being affected in general population is about 0.3%. If there's a first-degree relative, it puts you at about 5%. First-degree relatives were enrolled by TrialNet and studied prospectively. And as antibodies developed, by the time there were 2 antibodies, there was about a 70% risk in 10 years and about an 84% risk in 15 years. As these people were studied for a longer time, they would see loss of glucose tolerance, and at that point you can predict diabetes for at about a rate of 90%. So back to diagnosis in the clinic. There's 2 peaks of age, one around age 6 to 8 and another at adolescence. But it can be really diagnosed throughout the lifetime, even in late decades. But it is definitely more unusual after age 35. The symptoms, and again, this is not exhaustive, but typically what you'll see is polyuria, polydipsia, weight loss, nausea, vomiting, potentially fatigue, polyphagia, and blurry vision. With these symptoms and a suspicion, what should the pediatrician do first? An overall exam and assessment of the illness level, as always, is really the mainstay. If there is availability for finger stick glucose, that's great for confirmation. Otherwise, if there's availability for urine analysis for glucose and ketones, that's really equally as good and helpful because you can really triage based on the presence of ketones and the level of illness. And the triage is basically looking at the level of illness. From the ADA consensus statement, the recommendation is to admit patients who require treatment for acidosis, require IV hydration, particularly young children and children who are from great distances away or have psychosocial challenges. At our center, we've used this and made it a little bit more specific, which I think may be helpful to you in terms of the numbers that are correlated with what we consider a significant level of illness for hospitalization, but they're pretty similar. And again, not written in stone. So if some of these are met, we still sometimes may be able to do this on the outpatient side. But generally, if patients are sick enough, they'll go to the emergency room and be admitted. If they're well admitted, we do try to do this in the outpatient setting, which we really find beneficial to parents and their families. Not all parents and their families like this, but I would say over 80% of them really do like to be able to go home and sleep in their own bed and are more revived for education over the ensuing days. But certainly some pediatricians and some families just don't feel comfortable going home that first day and feel that they could manage their child overnight. So when we have patients arrive in the clinic, we do send these blood tests. We also think about sending some of the blood tests for comorbidities of diabetes at that point and screen for thyroid and celiac disease. And we consider sending islet antibodies and maybe an insulin level if we're worried that we're not sure if this patient has type 1 or type 2 diabetes. Islet antibodies are pretty popular, and I'm going to spend one slide on them because it's always hard to remember what they are and how to order them. If you do send them, they're very, very good. They'll be positive in 98% of individuals. However, that's a little bit dependent on where they go, and there's some variability across labs. The other thing is that they are relatively expensive for a lab test. So if it's not a question mark, we tend to try not to send them because of the expense mainly. So during this first phase, either the first 1 or 2 days is outpatient or inpatient, we first talk about survival. And so the first couple things we go over is what is type 1 and how did this happen with the family. And then the nuts and bolts of how to check blood sugars with glucometer, how to give insulin with a syringe. We try to change the focus of the family from what they've been really feeling, which is hyperglycemia, and how to control it, to hypoglycemia, because that's going to be their main immediate concern once they start giving insulin. And then we teach them how to decide what dose to give when they get home. And then the rest of it, which is a process, is going to take potentially be a lifelong process. You know, we sort of also talk about it sometimes as the basics of kindergarten through elementary school all the way up to college, and that can take a while. So the goal that we're doing in our management is to basically recreate those beta cells that have been lost. And what does the beta cell do? The beta cell responds to the blood sugar and produces insulin as the blood sugar rises. And insulin acts as a key to deliver sugar into the storage tissues after a meal, but also in between meals, insulin controls the flow of sugar and ketones out of the storage tissues. So when there is no insulin, sugar pours out of the cells. New sugar that is consumed is not stored, so the blood sugar rises. Also, sugar is not available for use as energy, so the body switches to using other stores of energy. Metabolizes fat, which is a problem because the byproduct is ketones, which is produces acid. and then leads to decay. So in sum, there's no insulin. There's the immediate concern of decay from breakdown of fat, and the long-term concern of organ damage from the high blood sugars, which are toxic. So in recreating the beta cell, we do this with insulin to match how the insulin is usually produced by the beta cell. To match the part where the beta cell is making insulin to keep the stores from pouring out sugar, we use basal insulin. And to match the insulin that the beta cells are making in response to blood sugar that rises after consumption of food, we use bolus insulin. And our ability to match this physiology has dramatically improved in the past 10 to 20 years with the arrival of the newer insulins. So for the basal insulin, you'll see either glargine, which is Lantus, or d.Cmr, which is Levemir. For the bolus, we use rapid-acting, which is Aspart, otherwise known as Novolog, Lispro, otherwise known as Humalog, and glulisine, which is otherwise known as Epidra. And we also have better technology that we can use to help recreate these beta cells using pumps and continuous glucose monitoring that I'll talk more about. So just to show you the pharmacokinetics of these different insulins, the older insulins, which many of you are familiar, were very popular through the 80s and 90s and still are being used in some regimens, some places, are regular in NPH, but they're fastly becoming extinct because they really don't match what the newer insulins can do, and they don't match what insulin does physiologically. And you can see this here where the peak is at about 2 hours, much later than the food would be absorbed, and there's a long tail of insulin action. And again, NPH has a peak of about 5 to 6 hours and a very long tail in it. And the problem with these regimens are that when you don't match the insulin to food, you're more at risk for high blood sugars, but you're also more at risk for hypoglycemia. So basal insulin, as I said, is now done with either once daily dosing of glargine, twice daily dosing of Levemir, or hourly dosing through the pump of a short-acting insulin. So this shows the pharmacokinetics of these insulins and how they do have much more of a peakless background insulin, which is what we want to keep the stores in check. The bolus insulin is given using rapid-acting insulin, either Humalog, Novolog, or glulisine, Epidra. And as you can see, this has a pretty quick peak, which matches the absorption of food pretty well. Certainly always better if it could be given a little bit before eating, and then has a much shorter tail in it. So the goal of the bolus insulin is to bring the current sugar into the normal range, as well as account for the absorption of sugar from the food that's about to be eaten. And we put this into a formula calling these two pieces of it a correction ratio for the current blood sugar, the amount that we think we need of insulin to bring the blood sugar down, and a carbohydrate ratio for the amount of carbohydrates to be eaten, the amount of insulin we think we need to sort of cover those carbohydrates. So that if those carbohydrates are eaten, the blood sugar will remain normal. That leads to the biggest question of how do we know how many carbohydrates it will be eaten? Is that too difficult or doable? And with the new technology available and the new resources, our patients are really able to do this almost to a last one. Certainly been helped by the fact that carbohydrates have been sort of heavily talked about in the media due to weight loss efforts that involve them often now. So people, compared to say 20 years ago, are much more familiar with what a carbohydrate is right off the bat. So as in this picture, you would imagine that a child eating a high-carb meal of a plate of pasta versus this low-carb meal here would need more insulin for this compared to this to maintain a normal blood sugar. Certainly, if the child gave the same amount of insulin, either here the blood sugar would be high, or more dangerously here, the blood sugar would be low. A cool carb-counting app is Figwe. We also use calorieking.com, which is really nice, and it has a website as well as a book that patients use. Here's a resource just comparing a bunch of foods and how much if eaten, would be the same, be 15 grams of carbohydrate. And here's the second page. So as I just mentioned, the bolus insulin is going to be partly based on a carbohydrate ratio and partly based on a correction factor. Carbohydrate, just to reiterate, ratio is going to hopefully bring the blood sugar back down to normal for the amount of carbohydrates eaten. And the sensitivity correction factor is to account for the amount that the blood sugar is above where you want it. Where you want the blood sugar to be is called the target. And we actually set that. Typically, it's going to be 100. However, before someone goes to bed, it may be a little higher, potentially 120 or 150, or throughout the nighttime. We picked these, and I'll show you how we picked this originally, but over time we individualize them based on blood sugar review for the particular patient. So each patient would have their own carbohydrate ratio and sensitivity correction factor. And here's a little bit is an example of what the calculation that the patients do. They basically take their blood sugar, subtract that target blood sugar, and divide that by the carbohydrate ratio, and then add to that the carbohydrate that they're going to, the number of carbohydrates they're going to eat, and divide that by their carbohydrate ratio. And they add those two numbers together and then round down to the nearest half unit, which is the smallest increment of insulin we can give via syringe. If they're using a pump, they may be able to round that down to 0.1 units. So a little bit on how we arrive at these magic numbers that the patients are using for their insulin dosing. So the total daily insulin dose is what we start off, and typically that's about 0.5 to 1 units per kilo per day. So that's based on the patient's body weight. We also take into account their age. A peripubertal child will need closer to 1, maybe even a little bit more, and a younger child will need closer to 0.5 or maybe even a little bit less. Once we arrive at that number, about 50% of that is given as the basal insulin, and 50% is given as the bolus insulin throughout the day. So basically, if you had the average for the total daily dose of about 0.7 units per kilo of body weight, and 50% is taken off as basal, the other part where you think about the carb ratio and the sensitivity is also calculated using the total daily dose. These are basically empiric numbers that were studied in patients with diabetes a long time ago to see if it would work, and sort of arrived at. The ones that we tend to use, other centers use very similar, sometimes a little bit different. And again, they're a starting point. Afterwards, it's adjusted per individual patient based on how the sugars look. So the carb ratio is 500 divided by that patient's total daily dose, and the sensitivity or correction factor is 1,500 divided by that patient's total daily dose. To look at this in practice, if there was a 7-year-old girl who would be about 20 kilograms, her total daily dose would be 10 units, so half of that would be her basal, so she would get 5 units for her basal. Her carb ratio would be that magic number 500 divided by 10, which is her total daily dose, or 50. And her sensitivity or correction factor would be that magic number 1,500 divided by 10, or 150. Something nice here that you can use as a quick check for when your patients come through with their doses is that because of the way these formulas are set up, the sensitivity and carb ratio have a relation to each other, and the sensitivity or correction factor tends to be about 3 times the carb ratio number. So what her order would look like is, with her basal being 5 units, it would either be given once nightly as Lantus, or potentially 2.5 units twice daily as Levemir. Or if she had a pump, basically this basal rate of 5 units would be divided by 24, because it's an hourly, it's pumped in hourly by the pump, and it would be 0.2 units per hour. And that could be done using any of the rapid insulins, Humalog, Novolog, or the Epidra. Her carb ratio would be 1 to 50, and her correction would be 1 to 150. So that's the ideal. And then stepping back, this is, for some, what reality is. It sometimes happens in the outpatient world, so you should look for this in your patients who have have insulin orders with type 1 diabetes. But it's very prevalent in the inpatient world, and this is the sliding scale. And this is dosing insulin before meals based only on blood sugar and not accounting for the carbohydrates to be eaten. I think the danger of this is best shown by looking at a quick example. So in this example, an 8-year-old girl with type 1 diabetes for 3 years, is admitted on the inpatient unit with cellulitis. She's afebrile and otherwise healthy, and it's breakfast time and her blood sugar is 320. She's tired, and when the nurse comes by to check her blood sugar and give her insulin for her pre-breakfast, she says she's not really sure if she's going to eat. So another question, what would the nurse do? If you look at her sliding scale and her blood sugar is 320, her dose would be 8.5 on the order. So the first question is, should the nurse give this 8.5 units of Lispro? Second, maybe give no insulin because she's sleepy and she says she's not going to eat anything. Third would be maybe give a different number of units of the Lispro. And 4 would be maybe give a different type of insulin. And the answer is C. Give a different number of units of the Lispro. But not give any insulin. What happened in reality? Because of the order, the nurse gave 8.5 units of Lispro. 2 hours later, our endocrine fellow was rounding, and the patient had fallen asleep. And with a check of her blood sugar, it was 46 at that time. And this is not unusual. It's a real problem, and it's been recognized by many, many different agencies. So, for one, the Institute for Safe Medication Practices identified insulin as an inpatient high alert medication. This is across all parts of the hospital, including the adult side. Insulin is frequently cited as one of the medications commonly implicated in medication errors in hospitals. Insulin-related medication errors have the potential to result in serious harm, including death. The American Academy of Pediatrics has really led the way on this and is emphasizing the importance of safe insulin use in children. In 2013, the American Society of Health System Pharmacists convened an expert consensus panel to address insulin safety in hospitals and really recognized that the sliding scale insulin has to be sort of gotten rid of across hospitals, but recognized that it really hasn't been. Even though on the outpatient setting, especially in people with type 1 diabetes, there's been a better move towards what we call like an insulin algorithm based on blood sugar and carbohydrates, but inpatient, the sliding scale is pretty prevalent. So in our hospital, we led an effort of getting rid of the sliding scale. And first, to think about what are the barriers, not dissimilar to the barriers that you have when you have a patient and their family, but of course, given history, harder to overcome. So historically, patients ate a prescribed amount of carbohydrates at scheduled meal times. But today, insulin matches carbs the patient wants to eat. So we have a different way of doing things, which we just reviewed. And there's a knowledge gap and some fear. How will the nurse or pharmacist know exactly what the patient's going to eat and how many carbs are in what they're about to eat? And the calculation, which I showed you with all the division and the minus and the rounding, is complicated. So what we did is we convened a group of pharmacists, physicians, nurses, nutritionists, and also the IT folks to make this happen and get rid of the sliding scale. I think the first important step was to label the menu for all patients that were admitted in the pediatric service who had diabetes. The dietary departments in the hospitals know the content of all the food, not just the carbohydrates. And so if you work with them, they can potentially pull this and put it on the labels. It's a great thing for this effort, and it's also just great for teaching tool for the patients, especially if they're new onset. So here's an example of one of the menus. Here's a little closer up so you can see where everything that they're thinking about ordering is labeled. And then working with the IT folks, we made a new insulin order. So you can see typically in insulin orders, and this is true at MGH, you have maybe you want a standard number of insulin you're going to give right then, stat. Otherwise, the sliding scale is a choice. And we added this new choice, which is called insulin algorithm. It's pretty easy to use. The fields are basically what we talked about. The physician needs to enter the carbohydrate ratio, the target blood sugar, and the sensitivity. They also choose how they want to round down to either 1 or 0.5, depending on the patient's age and need. The entry field for the nurse shows the insulin order at the top, so what's been put in by the physician. They need to enter the blood sugar and then the carbohydrates either the child's about to eat, if they feel confident that's an older child and they will eat all that's on their plate, or they can take the pre-meal blood sugar and wait and see how much the patient actually ate of the food that they were planning to eat, and then enter the grams actually eaten. Once they do that, it will pop up the answer of what to administer and show the work that was done, as well as the actual numbers that were for that particular patient at that particular time. So this has worked really well for us and been well received in our inpatient units, both in the ICU and on the floor. So back to our patient, there's some, will this algorithm and this new way of thinking about insulin help her so that she doesn't get insulin at a dose that she doesn't need? So can it work for someone who's not eating? Yes. It may be important that the blood sugar is high when it corrected down to normal, even though the person doesn't want to eat. And so what the nurse would do for the patient that we saw would be enter 0 in the carbohydrate field and only enter the blood sugar, and it would give the appropriate amount of insulin. It wouldn't cause her to go low. Another common question is, what about if the patient's literally asleep and it's the middle of the night and the blood sugar's high? Well, it also may be important then to not leave the blood sugar running high all night, and at that point we would give insulin. We may shift the target, which we can do, to a higher number, maybe 120, 150, so that it's a little bit less than usual, but we do want to correct the blood sugars overnight. And this is true both in the hospital and the same advice that we give to parents who are at home. So we talked a lot about insulin safety and how we treat this, and what's our ultimate aim, though? We don't want to focus only on hypoglycemia because, of course, even though that's the immediate concern of safety in the short term, the long-term goal is to not have diabetes complications, and that is going to be achieved by having a low hemoglobin A1C. And this year, for the first time in many years, the A1C recommendations have changed in a good way. And these changes really are brought about by the fact that we do have newer insulins, we do have pumps now, and we can achieve better blood sugar control without the risk of hypoglycemia, which we had with some of the older insulins such as NPH and regular. So the older recommendations that had been recommended up until this year were that younger children, 0 to 6, would have an A1C of less than 8.5, but greater than 7.5 because of the real concern about hypoglycemia that we used to have. School age was less than 8, and adolescents and young adults was less than 7.5. This is all gone now, and the newer recommendations are that all pediatric patients have a goal A1C of less than 7.5%, very close to the adults, where it's less than 7%, and it's always been there. What does that mean in terms of the patient's blood sugar goals? That would translate into a pre-meal blood sugar of about 90 to 130, which we target, and an overnight of about 90 to 150. Another way to look at that is that each A1C does correspond to an average blood sugar throughout the prior 3 months, and a 7 would be an average blood sugar of about 170, and 8 an average blood sugar of about 205. And that would include all postprandials as well, even including the few hours in between, when the blood sugar spikes right after eating. So how important is this? The answer is very important. We don't want to let a patient sit at 9 if we can work with them and get their A1C down to 7.5. And the biggest demonstration of this was in the largest, most important trial ever done in type 1 diabetes, which is called the DCCT trial, which stands for the Diabetes Control and Complications Trial. It was published in 1993. 1,441 patients were enrolled with type 1 diabetes from 29 centers throughout the late 80s. And the patients were either given the typical regimen that was done in the late 80s or more intensive insulin therapy. The typical regimen, or termed conventional in this trial, was 1 to 2 injections of insulin daily, not usually titrated by blood sugar. You may remember this. They may have had 2 doses of, say, 70-30 insulin that they gave BID before maybe breakfast and dinner. Intensive was 3 to 4 injections of insulin daily, titrated by blood sugar, diet, and anticipated exercise. Patients were followed for complications. Interestingly, the study was terminated early because the results were strong enough that they felt that no one should be in the conventional group anymore and all should be in the intensive. Here is one of the slides from this study showing the A1Cs that were achieved. So the conventional group was right around 9%, and with the intensive therapy, they were able to get the A1C at 7%. To think about what that correlates in terms of blood sugars, they did pre- and postprandial blood sugars before breakfast, before lunch, before and after dinner, and at bedtime. And it shows that basically what we talked about, you want the pre's to be sort of in the low 100s, and the post can rise up to higher 100s. And here's one of the examples of the outcome. It was very similar in terms of retinopathy as well as kidney disease. So I'm just showing this slide. Is an example of basically all complications, microvascular complications. And it shows following these patients out, those that had the conventional treatment had a much higher rate of this late complication. Those treated intensively had a much lower rate. So really proving that you want to stop and get everyone treated more intensively to not have these long-term complications. So it's a hard thing, and we do have some tools, which I referenced earlier, and I'm sure you're seeing that technology has come along with. Insulin pumps are great. They basically take the place of all the injections, and I think their biggest thing is that they're a tool for patients, that they don't have to have the injections. They can wear these pumps with an insertion site in them for 2 to 3 days. We typically say 2 days. And all the insulin runs through there. Inside the pump is essentially what I've told you. We load up the carbohydrate ratio, the sensitivity or correction factor, and a basal rate. And so the pump will respond much as the nurse does in those orders I showed you, where the patient will put in their current blood sugar and their carbohydrates to be eaten. The pump will run the math, and it will spit out a dose of, say, 2.3, 4.5, and the patient will say, okay, to dose. And the insulin will be administered to the patient. So these are some nice ones, just pictures of what they look like. This is where the computer is to do those calculations, and in this case, the insulin reservoir is also in here. The insulin runs through this little tubing, and there's a little insertion site there that delivers the insulin subcutaneously. There's also this one where the insulin reservoir actually sits on the patient, and in this one you beam the needed dose from this little computer over to the patient. Newer and another great advance is continuous glucose monitoring. This has been around for a little while, but its accuracy is really just coming into its own now, and so more and more patients are being prescribed these. This, again, similar to this system, has a little piece that you wear that monitors the blood sugar, and it beams it to this device that the patient can put in their pocket or in their bag. It is basically filling in the black hole of what the blood sugar is all the times you're not checking it. Checks the blood sugar every 5 minutes, and it gives a screen where you can see where your trends have been the last couple hours, or you can zoom out and see it for a greater period of time. You can also upload this to a computer and see where you've been for the past couple weeks, including overnights. It also, so it allows for sort of real-time intervention in that you can see the blood sugar. If it's high, you can go over to your pump or give an injection and correct it. If it's low, you can intervene by taking a sugar tab. It also has the ability to set alarms, which the patient can choose, so they can tell the device when they want to hear the blood sugar is high, when they want to hear the blood sugar is low, which is good for safety and for corrections. In the end, though, it's half of it is probably these devices and the problem with needing to prick yourself and give insulin through an injection. The other half is to have to think about this all the time, feel isolated, and sort of incorporate this into who you are. So it really does take a village to take care of patients. So put the patient here in our pediatric realm. The patient sits within the greater family, who is their main support. Our team is here, and it's really important that a diabetes center have these pieces of a team: a patient care coordinator, a nursing staff with CDE recognition, so that they've been certified in diabetes education, physicians, nutritionists, social worker support, and also psychiatry support is incredibly important. Outside of the center, pediatrician is incredibly important for support. Organizations, the JDRF, which focuses on type 1, ADA, which focuses on all diabetes, but does have, in many states, an active type 1 diabetes arm. And the camps in the summer are so great for patients feeling connected and learning about how to take care of diabetes and becoming more independent and just having fun. I put one slide in here about the future, which is really exciting. As we've reviewed, there's been a lot of changes already in the past 20 years, even in the past couple of years. And the future is even more exciting. There's some prevention trials, preserving beta cell function with immune therapy to stop the attack of the immune system on the beta cells. So that's been run in trials already in new onset people with type 1 diabetes, and is also now in trials in some of the patients who have a couple antibodies and maybe some loss of already blood sugar control at a 2-hour time point, and are enrolling in these trials. Another frontier will be decreasing exposure to the trigger. So with the enterovirus, could it be a vaccine? Could it be changing from to breastfeeding from cow's milk formula? Could it be vitamin D repletion? All these are in trials as well. Technology is continuing, and bionic pancreas is very exciting, where instead of the patient having to be sort of in the loop of responding to blood sugar, going over to their pump or injection and giving insulin, the bionic pancreas would just do that based on an algorithm, which is really exciting. And stem cell approaches are coming along as well. Several groups, including Doug Melton's group at Harvard, are working with human stem cells and have recently published breakthroughs in terms of creating cells from stem cells that produce insulin in a responsive way to blood sugar, and they've put them into mice and cured their diabetes. The work would be to put these into human trials and then find a way, either through immune therapy or even better, it would be a barrier so that they're not attacked by the patient's own immune system. Okay, I'm going to switch gears a little bit and talk about diabetic ketoacidosis and its treatment. And for here, start with a case of a little boy who has presented to the office, 2.5-year-old with polyuria polydipsia and fatigue. Presents as typical on a Friday at about 11 a.m. All night he had abdominal pain. He vomited once in the middle of the night and twice this morning, and now he's arriving. He's noticed by the pediatrician to have decreased responsiveness and rapid heavy breathing. The office has an ability to check a blood sugar, and it's 458. And the child is sent immediately to the emergency room by ambulance. As this patient arrives to the ER, he's somnolent but rousable, and when he does wake up, he knows who his parents are. He is breathing quickly and has dry mucous membranes, and his blood sugar is quite high, and he's acidotic. So this is sort of the type of decay that is the most scary, severe DKA in a young child at presentation of diabetes. So, quick question. If you were in the ER receiving this patient, what would you do? Run back to do the calculations in the back room, intubate, give bicarb, pH is 6.9, give mannitol. He's very sleepy, not quite completely responsive. And the answer is none of the above. What's the main thing you should be worried about? Cerebral edema. So what should you do? The answer would be to pull out some sort of cheat sheet, either the one that I'll present to you now or some other way that you've thought about this before this first case comes and how you're going to organize your thoughts. Not to leave the bedside. Try to stay near the bedside the entire time and manage coordinating care from there. So this slide is in purple for a reason, because a piece of it is to kind of really calm down, because I think there's a real reason you're in the ER and this child's very, very sick and very, very young to sort of freak out. And you really want to look at this purple slide and say, no, there's time here. In fact, maybe I should slow down. The reason I say this is that the biggest complication is what we just showed, cerebral edema. And the way that we think, even though we don't have a lot of data, that this may be happening is that, well, we do see it sometimes at presentation. It's also results from care during these first couple hours. And most data suggests that if the care is done more slowly, correcting everything in a slow manner, the patients will end up actually better in the end. And that's, again, our number one reason that patients have a problem here. So you do want to kind of take a deep breath and think, okay, I don't want to rush things. I don't want to start running tons of insulin and tons of fluid and correct everything really fast. I don't necessarily want to give bicarb if I don't have to. I want everything to sort of correct itself slowly, just as the patient got into the situation slowly. So with this management flow sheet, I've arranged it this way on purpose to think about 3 tenets of treatment. One is going to be correcting the fluid. One is going to be giving the insulin. And the third is going to be constantly monitoring their neurologic status and intervening quickly if there's a suspicion for cerebral edema. A couple notes on the fluid. It's very hard to assess fluid clinically in someone with type 1 diabetes, and thus we typically will just estimate it at 7 to 9% dehydration. You don't want to bolus too much. Often, of course, the patient will need a bolus, potentially 1 to 2 boluses of 10 cc's per kilo right at the beginning. Try to stay there, maybe give a third, but that would be rare. And replace the rest of the fluid deficit over the next 48 hours. One thing that we found important is probably not replacing the urine losses over this time, because that can sometimes lead to too quick correction. So just the 48 hours of what is estimated as the fluid deficit. You don't want to use anything less than half normal saline, but you certainly can't go wrong by also giving half normal saline or normal saline as that fluid correction. And importantly, all these patients, even if their initial potassium is not low, will be total body depleted in potassium. And so once the patient is voiding, you want to add back potassium to their fluid. Insulin is interesting. Often there's a rush to give insulin. In some centers, an insulin bolus is given. And the literature really doesn't support that. In fact, the newer literature suggests that waiting for this fluid to get started, even an hour or 2 hours before starting the insulin drip, is maybe preferable, but certainly fine. So at that point, start the insulin drip. It's always started at 0.1 unit per kilo per hour, unless there's something very significant about the patient that you think they might be insulin resistant. But typically it's going to be 0.1 units per kilo per hour. And as the blood sugar drops, you want to keep the insulin running to clear the acidosis and add back dextrose to the fluid. And the third column here talks about assessing neurologic status, as I suggested. And it's really important to continually monitor this and not put the patient in a sort of in an area of the ER where you can't see them and are just monitoring their labs, because you really want to wake this child up in particular, every hour to make sure he still knows who his parents are, he still knows where he is, and that he's not worsening. If he is worsening, you may suspect cerebral edema. You do not want to send them down to radiology for a CT. You want to quickly treat this with most likely mannitol. I put this in here just in case you have the opportunity to print it out. It's the more detailed DKA flow sheet that we use at the hospital, and you may find it easier to use as it's very specific in terms of all of these things, and a nice 1 page to carry around, although we can't read it without printing it. So just to reiterate, why do children with DKA die? It's definitely cerebral edema. Accounts for 57 to 87% of all DKA deaths, so it's the number one complication that we're worried about. That being said, it's very hard to study because children dying from DKA is very rare. And so the population-based incidence is low, 0.46% in Canada, 0.87% in the US. And the rate of mortality once a patient has cerebral edema is still generally low, 21 to 25%, but there's significant morbidity in another 10 to 26%. How does cerebral edema look? Just to go into this in a little more detail, often there will be headache, deterioration in level of consciousness, inappropriate slowing of the pulse, or increased blood pressure. If you've been monitoring them and seeing it change, can be a very important sign. Typically, it does present about 4 to 12 hours after treatment has begun, so that's something to think about as well. In the flow sheet, the detailed flow sheet I showed you, we have this, which is basically instructions for the nurse to follow everything closely, look at the heart rate, and look for widened pulse pressure, and also these criteria, which sort of solidifies basically when you're going to call something clinically cerebral edema. So if there's one diagnostic criteria, which would be an abnormal motor or verbal response to pain, of course, decorticate or decerebrate posture, cranial nerve palsy, or abnormal neurogenic respiratory pattern, that would be any of those. One would be diagnostic of cerebral edema clinically. If the patient starts to exhibit two major criteria, which would be altered mentation, sustained heart rate deceleration, or incontinence, that would be two of those would suggest cerebral edema. Or if there's one of those major criteria, and two minor criteria. Minor criteria would be the vomiting, headache, lethargy, or blood pressure changes, and potentially even just a young age is minor criteria because it's so much more likely to happen in someone under 5 years of age. You would think cerebral edema. So hopefully these would help you to diagnose this clinically, start treatment, and not feel like you have to rely on a CAT scan so that you can get things moving earlier. To go a little more specific, what you want to do is reduce fluid rate and administer mannitol. But I also want to mention, because some centers have better access to hypertonic saline, a lot of the ICUs, especially pediatric ICUs, are more comfortable with it, and hypertonic saline is coming along as probably also a reasonable alternate. Of course, the mainstay of treating DK is preventing DK and not getting to that state. The main reason to get to that state is by far noncompliance. I put this picture up here because, you know, for some patients, this is an overwhelming thing. This is what it looks like that is happening to them all the time with insulin. But again, it's not just the needles, it's also sort of the cognitive dissonance that this is not something I'm going to accept and deal with. And that's where we get back to some of the technologies that have helped us. The insulin pumps can be really helpful for patients. And the continuous glucose monitoring has been really great in terms of moving us away from DK and having patients have an easier way to take care of this. It's less cumbersome. But again, it comes back to the village and everybody supporting the patient so that they can continue on this sort of tedious day in, day out care for managing their blood sugars. Finally, I just want to go back to the course objectives and give the answers. So we wanted to understand the etiology of type 1 diabetes, and type 1 diabetes results from an immune attack on the beta cells. Understand the main principle of management, which is to recreate the function of the beta cells. Understand how to choose a dose of insulin. So the rapid insulin is going to be based on the blood sugar and the carbohydrates to be eaten, and not the sliding scale. And then understand the basic precepts of DK management, correcting slowly, and frequently assessing neurologic status.